also the environment in which it's happening and how that's changing, the way societies are changing. Societies in West Africa are not the same as societies in the Democratic Republic of Congo in 1976, and therefore our response to events has got to change. And overlaying the way that these communities are interlinked with the rest of the world. So the drivers of these emerging infections, and again, I put drug resistance as the most important emerging infectious issue of our time, are multifaceted. The recent terrible events in Kathmandu, the recent events in West Africa just demonstrate that these issues arise they do not arise in the absence of understanding the culture and the environment in which they're arising. So whether it be earthquakes or whether it be war or civil war or disconnects between the governed and the governing puts enormous challenges on the emergence of infections and the ability of the health systems to cope with it. So on top of the hotspots around the world of where environmental factors may lead to the emergence of new emerging infections or drug resistance, etc., we have to overlay on top of that the ability and the resilience of the systems that can cope with it. If we don't put those together, we won't understand where the risks and threats lie, and we won't be able to address the underlying issues. You cannot, in my view, separate these two. Environmental and climate change will lead to many, many changes, some of them unpredictable, some of them predictable, but they will certainly have an impact, for instance, on mosquito populations, tick-borne, etc., will change in the way they are spread around the world. And society itself is changing. We're going from rural to an increasingly urban society, and the urban societies do act anthropologically and interconnected in ways that is different in the ways that rural communities act. And the drivers of this, I think, underpins many of the emergence and challenges we face with infections. Counterfeit drugs, crucial issue, I think, both in terms of individual patients and populations not getting the drugs they need, but also in the emergence of drug resistance. If you have a tablet, an injection, etc., with no drug in it, that's one thing. The individual will suffer dreadfully. If you have a counterfeit drug with 20% of the ingredients of the antibiotic, antimalarial, anti-TB drug, anti-HIV drug, that's a second issue. If it's 50%, if it's 70%, if it's 90%, then this will have profound implications for both treating individual patients, the population in which they live, and the emergence of drug resistance. Zoonoses, obviously, I won't go into any more details. And lastly, of course, the interconnectivity. The ability, I first came to the UK, I got on a boat in Asia, and I arrived in Southampton docks, and I've supported Southampton ever since then, actually. I arrived at Southampton docks 6.5, 7 weeks later. If I'd got on with a dreaded lurgy in 1970, whatever it was, I would have either have got over it by the time I arrived. Now, of course, you can be there in 12 hours, and I would imagine there's people in this room who yesterday were in some more distant place. That is a potential capacity for us to spread things around the world much more quickly than in previous eras. The other thing is these emerging issues happen very, very quickly. 1918 was the thing we all are terrified by, the pandemic of 1918 with 20, 40, 50 million people killed in a world with about 2 billion people at that stage. This is a very beautiful graph. This is months of the year. This is October 1918. These are 4 cities, New York, London, Paris, and Berlin. And the important thing here is this is mortality, and this is excess mortality. And you can see that in individual cities, the upswing of that epidemic and the downswing, there were further waves across here. In individual places, that peak of that epidemic went up and came down very, very quickly. The take-home message for me in that is if we're going to act, we have to act in a speed which is hitherto been unthought of. We are now 15, 16, 17 months into the Ebola epidemic, and our capacity to respond to it, as MSF has led, is just not in the time frame that's consistent with where we have to be if we're going to act more quickly. And again, whilst I believe that surveillance is absolutely critical, and sharing of information and knowledge of what is and what is not happening is absolutely critical. The truth is surveillance picked up Ebola in January or February of 2014, and apart from MSF, the world did not act until August, September, October. So surveillance was in itself not the problem. it was our ability to act. If we don't add a response mode to our ability to gather the information, then we will continue to be, dare I say it, stamp collecting around the data. We have to add a component to it. This is Mexico, and the only reason for showing this of the pandemic is because it follows a very, very similar pattern. This is the center of Mexico in 2009. So when I look back, and I deliberately have not chosen Ebola to frame this talk on, and I've chosen something very different, but which I think has the same implications, and that's the pandemic of 2009. But actually, and not deliberately, but I have actually, for reasons that escape me a little bit, been very directly involved in SARS. Carlo Urbani, who first raised the issue of SARS in 2004, and closed the hospital in Vietnam, which essentially saved the country from desperately suffering from the SARS epidemic, and lost his life in doing so. Very involved through SARS. Actually, it started with Nipah, 1998, H5N1, enterovirus 71 in Southeast Asia at the moment, viral hemorrhagic fevers, hemolytic uremic syndrome, H7N9 in China at the moment, cholera, MERS-CoV, drug resistance, and Ebola. And I have, in one way or another, been involved in all of these. I think in parts of the community, people have improved dramatically. There is much better surveillance now than there was. In the old days, we would never have known H7N9 was appearing in China. Now we know of it. And in fact, in some ways, we have too much information now. You will know in 2015 if there is an HXNY influenza, avian influenza, in Outer Mongolia. You will know. That will be picked up, I would imagine. So I think the surveillance and actually the sharing of data can certainly be improved, but compared to where it was a decade ago, we are in a much, much better position. I actually think that international cooperation, but we can come back to that, has been reasonably good. And overall, although it's easy to criticise, I actually think the media have been involved in many of these in actually mostly a positive way. I think the community which has failed to step up to the mark is my community, and that is the patient-orientated research community. And I think because of fragmented services, and I believe a major component of stifling regulation and conservatism, we have not combined with, collaborated with the individuals working in other sectors such that we can start to do the essential work in that very short window one has to learn what one can do to make a difference. There are enormous practical, there's huge ethical, there's huge questions about subsequent access to information, data and samples, and huge access to further treatment. But the window of opportunity to change epidemics is early in their natural history. And if we don't gain the ability to act at that time, I fear we'll keep going through the mistakes of all of these. MERS-CoV is a very good example. The first case of MERS-CoV, off the top of my head, was diagnosed actually in this city in September 2013. We are now in May 2015. We don't understand the epidemiology. We don't understand the animal reservoir. We don't understand the transmission dynamics. We have not worked out how to treat individual patients or prevent secondary transmission, and we do not have a vaccine. That's true of every one of these. So if you ask a very simple question, and just remind everyone, I'm a clinician, not an epidemiologist. I'm a clinician. But if you ask for influenza, arguably one of the infectious diseases which could cause global catastrophe, if you ask the question for influenza, who do you treat, with which drug or not, at what dose and for how long? Do we understand which drugs to use, understanding the pharmacology, the PK-PD relationship, the interventions that may work beyond therapeutics to prevent secondary transmission? How does resistance to the drugs that we do have develop? Do we have vaccines which cross more than a few strains? And what works in the setting of a clinical setting? This is a disease which 16 to 20% of the world's population were infected by in 2009, and yet out of that period, 4 years later, I don't believe we can answer with general agreement and consensus the answer to any of these questions. And again, I think that has been true of every single epidemic and pandemic that I refer to above. Such that at the end of 2013, the World Health Organization, in their great wisdom, were able to say overall the quality of the body of evidence was very low to low, leading to WHO global recommendations for the treatment of a hugely important infection, a strong recommendation, very low quality evidence. I am a native English speaker. And I could not tell you what that would mean as a clinician with a patient in front of me with flu. And that's not WHO's fault, in my view. That's my community's fault for not addressing that issue. Leading to headlines from a very esteemed, in some quarters, journal, British Medical Journal, stating very boldly that oseltamivir does not work. I'll go on. And part of the reason is, I believe, that stifling regulation and complexity and conservatism that we brought to what I call human subject research. This is a patient with something quite badly wrong with them. This is a youngish clinician who's got a bright idea. The pathway that young clinician takes, probably early or mid in their career, when they're terrified of where their next job is to go and write a protocol. This is the previous drafts of the protocol. They're now on protocol version 563. They then, and if any of you have not watched the YouTube video on teleconferences, please email me and I'll send it to you. It is one of the funniest YouTube videos ever. They often then go to a teleconference. When we were living in Asia, that always included people in Europe and in North America, and for some reason North Americans could never be out of bed in the middle of the night, so this was always at 2 a.m. Asia time. You never really understood what anyone was saying. You couldn't hear what... Anyway, they seem to be very, very important in this whole process, which led to version 896. And this young doctor, clinician, nurse, whatever they are, then goes back. Anyway, by day 611, it's improved a little bit since then. It's now 609. But this is the average time in 2011 that it took from bright idea to enrolment of a first patient in a clinical study trying to find out what was wrong with them or how best to treat them and their families or their communities. We don't have 611 days in the emerging infectious disease world. Bear in mind that 42-day, 6-week window when the epidemic curve often goes up and down and your greatest capacity to intervene is early on. And then finally, that's only to recruitment and, of course, to completion of the study, writing it up, getting all the kudos, presenting at a meeting, publishing the paper and moving on to your next job, takes you into about day 1,000, which no young clinician would dream of going into if they had any sense. And that is one of the reasons why I think we're moving away from clinical research, which I think is so critical to the future. So I believe health research, and particularly my area, human subject research, needs a new paradigm. Yes, we do have better surveillance now, and we will identify things. In fact, as I say, we will identify potentially too many, and we won't understand the biology to know whether HXNY now to Mongolia is going to cause a global pandemic or not. We have to get smarter in our surveillance. But we cannot think that surveillance on its own, without the ability to act, is going to sort out the problem. I think we need much more innovation in the design of research. We haven't moved human subject clinical study design on, in fact, in the last 20 to 30 years. And I think we, even now, in the events in West Africa, we are still having, in my view, sterile arguments about designs of studies and how one might do things. We can't do that in the context of an epidemic. We have to have much, much better appreciation of the views and perspectives of the community that we're working with, and that means very culturally sensitive times. I'm going to move on very quickly because I don't want to talk about Ebola because I know you dealt with that very quickly. 1947 was the setting up of the major global agencies, whether they be the United Nations World Health Organization, the International Monetary Fund and others, and I think there is a major question of what the role of all of these agencies in and their governance structure in a world that looks very different to when we had Yugoslavia as a member of that committee. The world has moved on and we need to move on the governance structures of that. We've tended to make things overly complicated. This is the view from Geneva, and yet on top of that, overlaying it, and partially because of all of our concerns about the global governance of health, we've invented new schemes and new systems and new infrastructures and new governance bodies, which looks to maybe supplant or take over from the World Health Organization, but which